Well, I am honored and thrilled that you all showed up today to listen to me speak, because I do have a big passion. And my passion is to try to educate people and empower them to achieve optimal health and learn from my mistakes. And boy, have I made some big doozies that I think everyone can learn from. And I made mistakes in my professional career and my personal life. My background is I was an OBGYN for 20 years in Phoenix, Arizona. And I was delivering around 30 babies a month. So my life totally got out of balance. I was exhausted and fatigued and was getting arthritis, but it was more than usual. So then I thought, oh, well, I went and got some tests done by my friends, my conventional doctor friends. I said, Mare, everything's normal. You're just working too hard. And so then I thought, well, maybe I'm just not eating right. So I decided, oh, I give prenatal vitamins every day. This should be great for me too. So I started popping some prenatal vitamins randomly, and then I thought I was getting a cold. And you learn, oh, vitamin C is great for colds, you know, with my limited training in nutrition, mind you. And so I went and took some vitamin C. Well, my condition got worse and worse and worse. And I gained about 40 pounds in over a period of a couple weeks as I continued to take my prenatal vitamins regularly, because I thought that would help my energy. And lo and behold, I was diagnosed with, went to the hospital, and after I was short of breath, and I literally did a delivery and said, something is wrong. I know something is wrong. And I went down to the ER, and sure enough, they said, you've got to go up to ICU, and you are in heart failure. So they diagnosed me with hemochromatosis, and that is prevalent among the Irish population, which I'm 100% Irish, and I had no idea. And so I was poisoning myself with the prenatal vitamins that are filled with iron, and vitamin C aids the absorption of iron. So this is a huge mistake. Another mistake is, in our prenatal panel that we did, anybody who gives prenatal vitamins out, they don't include a ferritin. And so it was totally missed throughout my whole life that I had this genetic disease that I was born with. And it can easily be treated if it's caught early. But mine was a delayed diagnosis. It was so bad. All my organs were saturated with iron. I went into multi-organ failure. Mayo, and then I went to Mayo in Scottsdale, was airvac'd over there because I was so bad. And I'm still kind of in denial, but then they said that I'm not going to live unless I do a heart and liver transplant immediately. And I was like, oh, I don't think so. I said, just get me stabilized. And then I went home, started reading and got involved, and that's how I got my pathway to integrative medicine. So I had to get rid of the iron. You have to be phlebotomized to pull the iron out of all my damaged organs. Mayo would not do that for me because I was a heart patient. And they said, if you're anemic, it'll put you back into heart failure. So thank God I was a nurse before I went to medical school. So I just called all my nursing friends, said, come on over, can you help me pull out some blood? And so I literally did that for 2 years, and also began studying and consulting with Mark Houston, and he's an integrative cardiologist, and got on a plan to reverse all my heart symptoms. And lo and behold, in 9 months, my heart was back to normal. My ejection fraction was 8% and went to 65% in 9 months, just by pulling out the iron. It was a long road, but I think that was a big personal mistake that I had made, is by randomly taking vitamins and also by losing the balance in my life, because I got so busy doing my work, I disconnected my mind, body, and spirit and ignored all my symptoms, especially when my colleagues kept on saying, oh, you're just doing too many deliveries, your labs are normal, you know. So that's kind of my story. But what my goal is for today is to try to help you identify the imbalances and how to do that, and also to know the nutrient connection, that you need to first start with a nutritional evaluation and what you need to know about bioidentical hormones, why we replace these hormones, and how to correctly replace the hormones and how to correctly monitor them, and alternatives in case the patient does not want to be on any kind of hormones. So achieving optimal health is achieved by creating a harmony within inside the body. And this is done by becoming aware of the imbalances we have in the body. And from my experience, and also from practicing conventional medicine for a number of years, traditional medicine does not go deep enough. The labs are too superficial. They took out a ferritin because of cost containment, which is only $8, from all the screening labs. So please add that back in when you're evaluating, because hemochromatosis it's 1 out of 4 in the Irish population who have this gene. And it's only caught if a ferritin is checked. So integrative labs are more in depth, and they identify imbalances, and they get at the root cause, and that's what we need to do, because in my training as OBGYN, it was you are trained to identify a disease and treat it with a medication, you know, and I think with integrative medicine, it really opened up my eyes to look at the whole body. Stop having the tunnel vision of just my specialty, because you got to look at all the different parts because they work together. We have to create a harmony within us. So the first test that I do on all my new patients is a SpectraCell, a micronutrient panel. This is an intracellular evaluation of amino acids, minerals, and vitamins. And I like this because instead of asking the patient, how's your diet? Everybody says, oh, it's great, you know. But here now I have objective data to see how they are actually assimilating and putting breaking down their foods and putting it into their bodies. It will provide you with a baseline of where their imbalances are. Like if they have, it'll give you an insight on their gut health, because if you see that they're deficient in many different amino acids, minerals, and vitamins, then their gut's not functioning. And then you think, well, why isn't it functioning? So then you can get more into depth and getting at the root of the problem. Like if they have a zinc deficiency, then you know that maybe they don't have enough acidity in their gut. So because you need acidity in the gut to produce zinc. If they have a glutamine deficiency, that's deficient lot with gut inflammation. So it kind of gives you a path. If they're low in all their vitamin Bs and vitamin C, and hey, then they may be stressed out. They may have more stress than what they know. So it really kind of helps give you more of a wide span of what's going on. Yeah?
Can you give more information about where we can do these tests too?
Sure. SpectraCell, Mary's usually here. Mary Tootie is the SpectraCell rep for the area, and I think we could provide you with her information. And
you can contact any of us, and we'll be able to provide the SpectraCell representatives' names if you're in LA or in Orange County and San Diego. We're happy to do that. And use
sure.
SpectraCell.
I use SpectraCell a lot, and what's nice is it's usually if the patient has insurance, they will only charge the patient $165 or $195, roughly. It kind of varies, because it also includes the MTHFR evaluation, gene evaluation, which is important because 30% of the population have this genetic defect. And I'll talk further on why this is important to identify those individuals so we can help them. Let's see.
And if they don't have insurance, how much will it be?
Oh, it's like...
Repeat the question.
Okay, he was asking as far as SpectraCell, the cost, and if they have insurance, I think it's roughly around $195 to $165. If they don't have insurance, then it's probably like $400 or $500. But again, don't quote me on those. I don't do the money part, but we'll get that information for you. Another reason why we need to do SpectraCell, it's our building block. So we start with what the nutrition is because the standard American diet is sad, literally. Because look at the statistics. I was astounded how bad we are eating. We need to start and look at what our diet is. The Nutritional Examination Survey revealed 10% of Americans consume 5 servings of fruits and vegetables, less than 5 servings of fruits and vegetables a day. 40% had no fruit or fruit juices. 50% had no garden vegetables in their diet. 70% had no fruit or vegetables rich in vitamin C. This is really sad. So, and I think a lot of people are doing fast foods. They need to be educated, and this is where we need to start. We get chronic disease is because of this. It's because we're not eating appropriately. Nutritional deficiencies are common because everybody's stressed, like I alluded to before. When we're stressed, it consumes all our vitamin B's, vitamin C, zinc, magnesium, and we need to, and also as we age, we're not absorbing the foods and the nutrients as we need. It's been shown that as we age, our vitamin D goes down, alpha lipoic acid goes down, CoQ10 goes down. So these are important things that need to be replaced with our elderly population. Now, as far as nutrients and hormone connection, there's a big connection because a lot of the hormones, as I'll point out later on, are dependent on appropriate nutrition. For instance, vitamin C. Vitamin C is very important because it inhibits aromatase, which helps conserve testosterone. Aromatase is the enzyme that converts testosterone to estradiol. And so we need to know that vitamin C inhibits that, so it'll help boost our testosterone if we need to. And also, we need to know that it upregulates 3-beta hydroxysteroid dehydrogenase that is used to convert to progesterone instead of DHEA. And then it also downregulates by saving progesterone from the conversion of cortisol because of the cortisol steal. When someone is very stressed out, they're going to have lower progesterone. And we'll go over that later on as we go further. Now, testosterone is dependent on the zinc. Zinc is needed to form testosterone. Magnesium is also needed to raise free testosterone. Carnitine boosts dopamine to raise testosterone. Vitamin B5 is a coenzyme to the steroid production and deficiencies to lower testosterone. Vitamin D is needed precursor. Vitamin C, as we said, lowers aromatase. And then vitamin K is a rate-limiting step for testosterone synthesis. So now you see why the first test that we need to get is a nutritional evaluation with the SpectraCell. Because if you're deficient in amino acids, vitamins, or minerals, you're not going to get balanced. And maybe someone is low on testosterone just because they're deficient in zinc, and you don't have to necessarily replace them with testosterone. You can just give them a zinc supplement. So start at the beginning and see, so we can find a better balance. Okay, so the amount of certain vitamins and minerals, amino acids, you can't just take prenatal vitamins randomly because it doesn't fit. It sometimes can be harmful. And you can't just say to take one a day and that's it. Now we have the technology to tailor it to what supplements the individual needs. All we need to do is more in-depth testing. So your nutritional needs are dependent upon your lifestyle, your stress, your vitamin interactions, your genes. So one side does not fit all. So I stress to you all that your first test should be a SpectraCell analysis. Nutritional deficiencies can also affect the conversion of T4, your inactive thyroid, to T3. So this is another instance where you want to really do a nutritional evaluation, because if you're low in selenium, chromium, zinc, iodine, copper, this could be the reason why the patient has hypothyroidism. And they have a great medicine, Biotics is a great supplement to take. And this could correct if you get and that's, again, a mistake I made in my professional life. I just ordered TSH. Oh, just a TSH. Let's see what that is. That will tell me if they're, and I'm missing the whole picture. I miss Hashimoto's. I miss if they do have a nutritional deficiency, because I won't identify if their T4 is real high and their T3 is real low. Hey, bingo, we got it. There's a nutritional cofactor that's missing. And maybe we don't need to put them on a thyroid. We just need to put them on a supplement to help the conversion to T4 to T3.
So real briefly on that, with medicine, that T4 to T3 conversion takes place where? in the liver, lungs, and also kidneys. And so one of the most important aspects when we do see a low T3 level, and we're looking at a panel, is to go, do we need to do a detoxification? What sort of liver support do we have? As far as the lungs, so many times there's an infection in the lungs, bacterial infection or whatnot, which could be hindering that conversion as well too, or also an infection in the kidneys. So this T4 to T3 conversion is really invaluable, and medicine, again, has all the nutrients involved to make that conversion possible.
This slide just kind of tells what Paul just said to us, that we do have the conversion of T4 and T3 in the liver, kidneys, and lungs, and that Medistim is a good product to support that. Other suggested baseline labs that we should do is a CBC, a chem panel, expanded lipid profile, hemoglobin A1C, your inflammatory markers, CRP, homocysteine, a 4-point salivary cortisol, DHEA, thyroid panel, PSA, and baseline hormones. And the reason for this is because you want to make sure you don't jump to just replace. Like when I was feeling sick, I thought, oh, I must be perimenopausal. I'll slap on an estrogen patch, you know. And I wasn't balanced. I was way out of balance. But what I'm trying to say is that we need to first fix the gut, then we need to fix the adrenals, then you fix the thyroid, and then you do the hormones. Because if you go to the hormones first, then it's like a dog trying to chase its tail. You're never going to get there. You know, at the first visit, I would not only do the SpectraCell, but I'd also do this lab. And then I'd have them come back. So
you will do all the labs together?
Yes, because I want to know if their adrenals are out of whack.
You recommend all of them together?
Yes.
These labs and
Yes, a lot of times these are paid conventionally. You know, the reason being is because if they have, say, for instance, if they have homocysteine and it's super high, they've got a methylation problem. And if they have a methylation problem, they're not going to break down the estrogen. And I'll bring this up later on. So they're not going to be able to metabolize their estrogen. And I don't want to hurt the patient. And if they can't break down the estrogen appropriately because we haven't identified this methylation problem, then it's going to put them at risk for breast cancer, right? So, and if someone has elevated PSA, I don't want to put them on testosterone, right? I want to correct that first, right?
And you will send it to the same lab or different lab?
Well, these are conventional tests, so a lot of times these will be paid by the insurance. So you probably wouldn't have to go through the SpectraCell because you want to try to utilize the patient's insurance as much as you can, right?
So this will go to like Quest?
Yeah, Quest or Southwest. These are conventional labs.
All of them in the same.
Yeah, yes, most definitely.
But then we need to go to 2 different places to draw blood.
For the SpectraCell, the lab kits, you can actually, when you talk to Mary, what I have done is Mary will mail the kit to the patient. The patient will go online and Google SpectraCell, and they'll put in their zip code, and then they'll tell them what lab. They just take the lab kit to the place, and they draw it for free, you know, including to the price. But in our office, we just do it all there because we do a lot of SpectraCell. Yeah, so either it goes to Southwest or Quest, or it goes to SpectraCell. So we have the SpectraCell kits in our office already. Okay, great question. Okay, so again, we want to balance in the order of balancing. We want to do the gut first, then we want to do the adrenals, then we want to do the thyroid. So that's why, and then the sex steroid hormones. And that's why it's important to see, you know, with that baseline labs, is to see if they're adrenals. A lot of people have adrenal fatigue, so you want to try to correct that because it's going to throw off your hormones otherwise. So why do we replace hormones? Well, of course, number one is the relief of symptoms, prevention of memory loss, heart health, bone production, and growth and repair. The only hormone that increases as we go through menopause is cortisol. And cortisol is an anabolic hormone, so it just breaks down the body. The catabolic hormones are your sex hormones. And so for myself, you know, when I got so bad and I was totally, my body was broken down, I am personally on hormone replacement therapy because I want to rebuild my body. I got to repair myself from all the damage I caused by taking prenatal vitamins randomly. So the symptoms that if someone comes in with hot flashes, in the olden days, I admit, I made the mistake. I'd say, oh, here's estrogen. Must be because of low estrogen. Here's estrogen. Hot flashes can be caused by many different reasons. And a lot of times just being stressed can cause hot flashes. So we need to identify things. And also if your thyroid's off, it can cause hot flashes. Infections can cause hot flashes. So the symptoms overlap as far as whether you have excess estrogen, progesterone, or cortisol, because they can mimic. And so we refer that lacking estrogen, as a lot of people assume that that's what it is. But I caution you to look outside the box and look at all the other organs too. Estrogen is a group of hormones that primarily influence the female reproductive tract in its development, maturation, and function. There are 3 major hormones that we produce: estradiol, estriol, estrione. And among these estrogens, estradiol is the strongest, and it's also the most prominent one. Cholesterol is needed to develop all the hormones. So, cholesterol first is broken down to pregnenolone, and then pregnenolone goes off to DHEA or to progesterone, going down to cortisol. So the steps of conversion for progesterone to the main estrogens, estradiol and estrione, is an intermediate step of the androgens, because estradiol is made from testosterone. So just to know the linkage and the precursors of each one and how they're all linked together is important, just as far as biochemistry, so you understand the underlying pathology of why we need to look at the adrenals and why we need to look at the thyroid, because they all work together. This is a slide that's from SpectraCell, and it's just to show you how all the vitamins that we have play a key role in your estrogen production and what kind of role that they play. So again, look at the SpectraCell first so you can replace any kind of vitamin deficiencies before replacing hormones.
Is this even between men and women? Or?
Yes, it is. Because I'll see, like I said, zinc is a good one in the slide that I showed you, how testosterone can be affected from a depletion of all those different things. And I'll mention it again when I go to the males. Great question. Okay, so estrogen in the brain fog. This is a common thing that I hear from a lot of patients. I think I'm losing my mind, or they walk in a room, it's like, oh, what did I come in here for? I've had that multiple times. And losing my keys. Oh my gosh, I had that multiple times. But I had a double whammy because I was being phlebotomized, and so I was very anemic, but I was very distraught because I was very, very independent from a young child. My mom tells me I raised myself. And then when I got sick, I lost my independence. And it was just devastating to rely on other people because I wasn't used to that. But thank God I had a lot of family and friends that supported me through my illness. But to make a long story short, I was determined to get back to have my independence. So here I'm going through menopause, and then I'm so anemic, I said, I'm going to do my bills today. And I sat down and spread them out, and it took me like 5 hours just to try to get the checkbook out. And I was so proud of myself. I accomplished a task. I'm on the road back to independence. But then 3 days later, I mailed them all back to myself. So brain fog's a big issue. I can pay my bills now, though, so that's good. But that's a good example of how the hormones play a big, huge role in our cognitive function. How does estrogen protect the brain? Well, it protects the brain by increasing the blood flow. It increases glucose and oxygen to the neurons. It protects the neurons. It increases neurotransmitters. It keeps the blood-brain barrier working. It increases sensitivity to nerve growth factor. And also, it decreases neuronal generation of Alzheimer's by helping decrease the beta amyloid peptides. Estrogen protects the brain also because it's a strong antioxidant. It increases the availability of acetylcholine. It also increases manual speed and dexterity. It boosts 30% of the NMDA receptors to maintain strength and durability of the synapses, and also decreases distractibility. So estrogen deficiency has been suggested to accelerate aging. Another study looked at, they compared that 28% reduction in mortality in menopausal women who were under the age of 60 who used hormone replacement therapy. So what you must know about bioidentical hormones. Oh, synthetic hormones are not the same as bioidentical hormones. So that's one thing, because your patients are going to think, hormones, oh my God, they cause cancer. They had that big scare. And I was practicing when the WHI study came out that was primarily done on synthetic hormones. And that can't be correlated to bioidentical hormones. They're separate. Synthetic hormones don't attach to the receptor like bioidentical hormones. Synthetic hormones waste energy by giving incomplete messages to the cells, which then fail to respond and produce a balance. Synthetic hormones is what was studied in the WHI study, and it has caused a great deal of misconception and fear in your patients about going on hormones. So it's our job to educate them and to make sure they realize that bioidentical and synthetic hormones are not the same. You can safely take a hormone replacement therapy as long as they're bioidentical and as long as they're correctly dosed and as long as we check how they're metabolized. And it won't increase your patient's risk for cancer if it's given appropriately and dosed right. So synthetic hormones are not the same chemical structure as the estrogen that our own body makes. For people, the synthetic hormones, the other names are Premarin. Estradiol and esterase that's more bioidentical. So it's kind of gets confusing. Like Provera is the synthetic progesterone. Prometrium is a bioidentical progesterone. And these are drug names that you've probably heard around in the past.
Do you find many people sensitive to the peanut in the prometrium?
Exactly. You have to watch. Okay, his question was whether the peanuts, the prometrium is made from peanuts. And so, yes, you have to watch for peanut oil sensitivities or allergies, and you need to be aware that this could be a problem. But that's an excellent point.
Would it be a good option or alternative?
Well, then I'd go to a compounding pharmacy and get it specially made up because actually a lot of times prometrium is not covered by insurance, but some insurances do cover, but that's something that everybody needs to know. Prometrium is bioidentical, may be paid by the patient's insurance instead of them having to go to a compounding center.
And if they go to compound, insurance may not pay?
Right.
Okay.
Majority of the time they do not pay.
Thank you.
Thank you. All right. So this is just a structure showing that the Premarin is made from horse's urine. So to show that Premarin is not the same as human estrogen. Bioidentical estrogens, medically natural estrogens, means that it is the same chemical compound that the patient has made themselves. So meaning that it'll attach to the receptor site well. It could be derived from plants. So, you know, when people say, well, your body didn't make it, so it's synthetic. Well, yeah, in a way, it is made by man, but it's the same chemical structure. So that's what we consider as bioidentical. Natural estrogens help protect against endothelial function by increasing nitric oxide, and that's how it can benefit us cardiovascularly. The vascular aging in women is estrogen the fountain of youth, is one question. Okay, yes?
I heard that when women taking hormone replacement therapy, they have a higher chance of a stroke. Is that true?
Now, that's a great question. Her question is taking hormone replacement therapy increases the patient's risk for stroke. If you take your estrogen orally, it'll go through the liver, and the liver will increase clotting factors, and yes, it could increase the chance of stroke. So I never give my hormone replacement therapy, my estrogen, orally. I give all my patients topical estrogen for that very reason, because that eliminates that risk.
So earlier, one of the slides said that estrogen increases the blood flow. So
Right.
does that mean it's causing bleeding or causing clotting?
No, it increases the blood flow by the way of increasing nitric oxide, which is a vasodilator. So in that way, when the blood is flowing, it can blow more freely because the vessel's dilating, right? Okay? All right.
So to add to her question, if the person's bioidentical was raising their estradiol or their estrone, could it still increase the risk for stroke if that's the mechanism it was creating? In other words, if you do the creams, are you safe from a stroke, or
If
do you
you're-
still have a risk?
His question is, if we do the creams versus oral estrogen, will it decrease the risk of stroke? Yes, because it's bypassing the liver. So when you give estrogen orally, it's broken down in the liver right away, and it increases your clotting factors. So if you give it topically, it bypasses the liver, and you don't get that added risk.
Would the clotting factors increase with estriol as well as estradiol, or is that simply an estradiol problem?
Estriol is 80% weaker than estradiol. Excellent question. He was asking if estriol is going to cause an increase in the clotting factors as compared to estradiol. Estriol will not have an impact of increasing clotting factors because it's so weak. But again, if you give it orally, it'll probably give it a little bit, but not like it does topically is the way you get away with that. Okay? Great. Yeah. Yeah.
Estrogen never by mouth?
That's my recommendation, and it's just because it makes more sense to me, because I want to minimize the amount of side effects that I give to my patients. And if I can get away with the clotting factors, and you'll see later on, I'll go over the different routes that you can administer bioidentical hormones, and then I'll point out why I don't give it orally. And it's supported by the scientific research. So, but in the olden days, I gave it orally. So that's another mistake I made. Sure.
With the clotting factors, extra enzymes, enzyme therapy helpful?
You know, since I do not give estrogen orally, but if someone wanted to give estrogen orally, if they gave lumbokinase or nattokinase, something to help thin their blood more, would that help? Sure, it's going to help somewhat. But why, you know, it's just like the conventional doctors give a drug and then you give another drug to help that side effect, so you don't want to fall on that route. Just try to avoid that side effect.
Can you just repeat those two, the nattokinase and what else?
Oh, there's umbilikinase and nattokinase. Those are, and vitamin E. Those are ways to thin the blood if people have problems with clotting. Okay, sure. Any other questions? Yeah.
You ever will give it to a man?
Pardon me?
You will give it to a man too?
Estrogen? Not unless they needed it. You know, a lot of times I try to avoid men from getting man boobs, so I try to avoid testosterone to go to estradiol by giving them aromatase inhibitors, right? But they do need some estrogen, don't get me wrong, but you just don't want them to have the man boob thing. So I do check estradiol on all my men that I give testosterone replacement just for that fact, because you want to be in the normal reference range. Anybody else? Great. Okay, so we have three types of estrogen: estradiol, estrione, and estriol. Bioidentical hormone only use compounded bioidentical hormones, or as I said, esterase is a prescription medication, and that's estradiol. And prometrium is a natural progesterone. You want to stay away from Primin and Provera. Those are the synthetics. Okay, The three estrogens, estrione, I feel is a bad estrogen, and I'll explain later on why, because it does have an increase in cancer risk in some studies. Estradiol is a good estrogen in small doses, and estriol is really good because it has been shown to have protective effects against breast cancer. Usually, when I replace women's hormones, I just replace estradiol and estriol only. And you never give estrogen without progesterone, even if they don't have a uterus, which I have done in the past, so that was another mistake I made. So, because now we know that all three of those hormones should be given. And you should give testosterone if it's needed, because they all work synergistically and they complement each other's function. So you'll get better optimal health if you replace all three.
So what would the ultimate risk factor be without, because that's typically what happens when they have the hysterectomies, they don't put them on progesterone.
Right.
I see a lot of people that and
right.
I just have gone along with that. What would be the benefit and what's the risk factor if they don't?
Right. So later on, I'll go over, his question was, what's the risk factor if someone just takes estrogen who had a hysterectomy and is not on progesterone and they don't have the balance? I'll go over, then they're going to be estrogen dominant, and I'll go over what the side effects later on and give you more information.
What was the logic, because they had the hysterectomy, what was the logic originally why they wouldn't put them on the progesterone?
Well, because we're just got the tunnel vision that I used to have, and we would say, okay, well, we always know you never want to give unopposed estrogen to someone who has a uterus because it'll increase the risk for uterine cancer. We know uterine cancer can be a result of someone taking estrogen only. And so the way I was trained, if you have a uterus, you have to give them progesterone. But they never really talked about balancing it all out, until I discovered, through all my integrative training, that we need to balance all three for maximum benefit. But, yes?
We know that estradiol and estrone can convert back and forth to each other, but
right.
we always thought estriol never did. And about 12 or 15 years ago, I remember CRT Labs was doing some studies, and they were saying that it was looking like estriol could convert to estradiol. Do you know? I haven't read any studies on that since then.
No, well, from what I've seen and what I've been trained and what I've read is estriol usually doesn't go back to estradiol. It just is a metabolite of estradiol and estrione. So
they were just saying in the studies that they were doing that it looked like estriol could convert into estradiol.
It'd probably be a small amount, if any. And estriol is predominantly elevated when we're pregnant. So that's the most common hormone when we're pregnant. But I haven't read anything like that. All right, so we must balance progesterone, testosterone, and estrogen. We must balance, as I said before, balance the adrenals first, thyroid, and then you go to your estrogen, progesterone, and testosterone. Okay, there's estrogen receptors in our body. There's alpha receptors and there's beta receptors. Alpha receptors stimulate and increase cell proliferation. The beta receptors do not. So when we look at estradiol, it equally binds to the alpha and the beta receptor. When we look at estrione, which is the reason why it increases our risk for breast cancer, is because it attaches more to the alpha receptors and so causes more cell proliferation. Estriol binds equally to the beta receptors in a 3-to-1 ratio. And this is so meaning it attaches so there's not as much cell proliferation. So when estriol attaches to the estrogen receptor, it won't cause so much cell proliferation like estrione does. Estriol, as I alluded to earlier, is 80% weaker than estradiol. So it has less of a stimulatory effect. Estriol is made in the body from the liver and from other estrogens like estradiol. There's considerable evidence to show that it protects against breast cancer. And because it attaches to the beta receptors, there's decreased cell growth instead of the alpha receptors, which stimulate cell growth. Experimentally, estriol has been shown to help decrease the incidence of breast cancer. It has been used to even treat people with breast cancer. It does not have the protective effect like estradiol does to our bones, our brain, and our heart. So that's the downside of estriol. But estriol helps reduce pathogenic bacteria and restore proper pH in the vagina. So I use, when someone comes in with vaginal dryness, I use estriol, not estradiol, because of this reason. And it also, the absorption, it goes to the bladder. There's estrogen receptors in the bladder. And you'll find a lot of menopausal women will come in with urinary tract symptoms, or they'll have more urinary incontinence. And all you could do is just give them some estriol, and it helps those symptoms greatly. They don't get as many UTIs. They seem to help their urinary incontinence. It also helps the GI tract to maintain favorable environment and growth of lactobacilli. Estradiol, oh, it has over 400 functions in the body. There's estrogen receptors everywhere in our body. It is cardioprotective, but I want to tell you that it's cardioprotective when estrogen is in the early phases of menopause. If you put a 70-year-old on estrogen, they won't get the cardio protection that they would if you started earlier. So you have to keep that in mind also. Vaginal dryness, I usually use, as I said, estriol than estradiol, but estradiol works, and you'll find people with that, but I think you get more benefits from the estriol than the estradiol. And estradiol has also been shown to decrease the risk of new onset diabetes. Estradiol, now when this is given topically, can increase HDL, decrease LDL, decrease triglycerides, helps maintain bone structure, increases serotonin, decreases fatigue, works as an antioxidant, helps maintain memory, helps the absorption of calcium, magnesium, and zinc. How awesome is that, you know?
Can I ask you a quick question?
Oh, sure.
You mentioned topically. Do you see the cream and the dot is a different mechanism, or are they the same?
Okay, his question was, do I see the Vivel dot is the same as the estrogen cream? The Vivel dot just has estradiol in it, so you don't get the estriol. And I like to balance people with a weak estrogen and a strong estrogen because you don't want to overpower them. But a lot of my patients, they say, no, I don't want to pay all this money at the compounding pharmacy. So the way to get around it is the estradiol, the Vivel dot, because you can use that, and it does work. You know, you just want to...
Estriol dot too?
No, they don't have estriol. They just have the estradiol. So that's the only thing that's in estradiol in the patches. So it is an estradiol. So that's the disadvantage, is you can't balance it as well. But I have patients on the Vivel dot because they want to utilize their insurance, and I have them on Prometrium. So that's another way to utilize the patient's insurances instead of having them pay out of pocket going to a compounding pharmacy. But excellent question. Then we got the bad guy, the estrione. And you know how I told you the estrione primarily attaches to the alpha receptor, so it stimulates cell proliferation. I feel estrione is the predominant hormone in menopause, so that's another reason why you don't want to replace estrione. And estrione is increased in people who are obese, and it's also associated with people with hypothyroidism, omega-6 fatty acid excess, and inflammatory cytokines. These are all associated with increase in estrione. So it has a significant, strong estrogenic activity, and studies show that it increases the breast cancer risk. And that's because estrione attaches to the alpha receptor predominantly. Now, a lot of patients will come in and they'll say, I don't want to take that hormone stuff, I'm going to get breast cancer, because they're all wigged out because of that WHI study on synthetic hormones. So I think it's our due diligence to identify these patients who are at risk and try to minimize the risk, and we can do that by reducing their stress, trying to make sure there's no dysregulation in the hypothalamus pituitary axis, making sure to replace what nutritional things that they're missing, because as I said before, if they don't methylate well, if they do have that MTHFR gene, That's a gene that's prevalent in 30% of the population. MTHFR enzyme is what helps us convert folic acid, which is inactive, to folate. And if we have that MTHFR gene, then we have a decreased ability to methylate. Methylation is needed for the breakdown of estrogen. If we have a poor ability to methylate, we may go down the bad pathway and then increase the risk of breast cancer. And I'll go into that later on, but I just wanted to bring that up at this time because there are genetic factors that we need to pay attention to. All right. So it's not necessarily the estrogen that causes breast cancer. It's the way we metabolize the estrogen that increases the risk of breast cancer. And that can change after we're in menopause. There's two major competing pathways, well, three pathways that estrogen is metabolized when it goes through the liver. It goes through to the 2-hydroxyestrone, 16-hydroxyestrone, or 4-hydroxyestrone. What we want to do is we want to try to get our patients to predominantly metabolize to the good pathway, which is the 2-hydroxyestrone. 2-hydroxyestrone and methylation. Now this is when I was talking about the MTHFR gene. If they do have that gene, which you can be identified if they have that gene if you get the spectra cell in the beginning. So then you'll know, hey, or if you get a homocysteine and it's elevated, those are suspicions they got a methylation problem. So you better think twice about how you're prescribing your bioidentical hormones to them, because they won't break it down to the appropriate pathway. So good estrogen, it does not stimulate the cell growth, and it blocks the action of the stronger estrogen. This is the 2-hydroxy metabolite. And the 2-hydroxy metabolite, some people have to have a COMT defect in the metabolization. So that's another thing that needs to be identified. And you can identify this by what I do is after the patient's been on the hormones for about 6 months, I will do a urine metabolization to see if they're going down the 2-hydroxy, 16-hydroxy, or 4-hydroxy, so I can identify if they're going down the wrong pathway, because there are things and supplements that we can utilize to help sway them down the good pathway, the 2-hydroxyestrone pathway.
Is there a particular lab you like to use to test for the balance?
Yeah, I use ZRT laboratories is predominantly what I use, their salivary. And then their urine tests, their metabolite tests are strips. So a lady doesn't have to carry around a jug all day, you know, so they're just strips. You just, they're 4 strips, and throughout the day they just check their urine with the strips, and then they send it in.
Which lab is that?
ZRT, Z as in zebra, yeah, ZRT. Okay. So 4-hydroxyestrone is the bad one. It can damage DNA, it can cause mutation, it can enhance cancer, and we found that the metabolization of Premarin goes down this pathway. And so that's why the WHI study was showing an increased rate of breast cancer among the patients in that study. And then is there greater quantities of these? This is when I was talking about the deficiency of folic acid and methionine, because that's, again, methylation. If you don't have appropriate methylation, you're going to metabolize to the 4-hydroxy. A lot of times people have uterine fibroids or they're obese, they're going to have more 4-hydroxyestrone, and you need to be aware of that. So if someone comes in and they have a history of fibroids, that's something that you have to be alerted to. 16-hydroxy has a significant strong estrogenic effect. Studies have been shown that it can be associated with an increased risk of breast cancer. High levels are associated with obesity, hypothyroidism, pesticide toxicity, omega-6 fatty acid excess, and inflammatory cytokines. Estrogen metabolism, the high, so again, we want patients to metabolize down the 2-hydroxy pathway, and if we identify through the ZRT urine metabolization test that they are not going down the 2-hydroxy, I talked about there are supplements that can influence us to make them go down that pathway. And supplements that have helped metabolize estrogen down the 2-hydroxy pathway are doing, or if they eat more cruciferous vegetables. But if they don't have enough vegetables, you can always take I3C, and that's indole 3-carbonyl, or DIM. That's another one that you can take. Those are supplements that if people don't like Brussels sprouts, broccoli, cabbage, the cruciferous vegetables. We can also help go down the 2-hydroxy pathway by having fish oils, flaxseed, exercise.
Quick question.
Yes?
There seems to be controversy for me as to which is better, DIM or indole 3-carbonyl. I don't have a sense of which one would be a better choice if you just used one, or should you use both? Do you have a preference?
Great question. His question was whether I use DIM or I3C as a supplement if I find someone who's not metabolizing their estrogen. I think both of them are equally as good, and I think one's cheaper than the other. I think it's DIM that was cheaper. So I tried to, since they're both doing it, I would recommend doing it. I'm pretty sure DIM's cheaper than I3C.
Thank you.
Okay. But no, I haven't seen a difference otherwise. Okay, other ways to make sure that the patients are going down the 2-hydroxy pathway or helping them going is doing omega-3 fatty acids or doing biotics products, omega-3, B6, B12, folate, because as I said, this will help with the methylation, especially if you identify that they have the MTHFR gene, then you want to use biotics product methylfolate plus. Another thing is TMG powder can also help with them if they have problems with methylation. Rosemary, turmeric is in Caparest. That's another way to help going down the 2-hydroxy pathway. And also weight loss, because we know that obesity, the people who are obese will have higher estrone. So you want to try to avoid that. And if you have a very obese lady, you want to be alerted that maybe you want to put them on I3C or DIM because they're at a higher risk because they have higher estrogen stores. So it's important to test. And I'll tell you later on as how I do, and that's why I wouldn't use estradiol. I like to use a combination of estriol and estradiol. If I have an obese lady, I'll do more 80% of estriol and 20% of estradiol. But I'll talk about that later on. Trying to help our patients so they don't we don't increase the risk for breast cancer. And I'll repeat again, it's not estrogen that increases the risk of breast cancer, it's the metabolization of the estrogen. And what we want to do, what our goal is try to get our patients to metabolize down the 2-hydroxy pathway. And as I said, we can do that with supplements. And we can also do that by identifying if they have a methylation problem. So we talked about that. This is another biotics products that will help our patients metabolize down the 2-hydroxy pathway. It is with BioOmega-3. These are capsules that contain 100 milligrams of natural marine lipid concentrate. And it's considered to increase fibrinogen and also help with rheumatoid arthritis, systemic inflammation, atherosclerosis, and other autoimmune problems. And you want to take 1 to 2 capsules of this 3 times a day. I am on this product because the iron deposited in all my joints, so I have severe arthritis. The iron also damaged my thyroid, and I have Hashimoto's thyroiditis, and I can contest that this does work. So it has helped my inflammation in my hands and my arthritis. So Caparest is also something that I do take, and the reason for is to try to bring down the inflammation from all the iron that deposited in my joints. Caparest works to downregulate NF-kappa B, and the ingredients in it is green tea, boswellia, turmeric, ginger, rosemary, resveratrol, and the fruit.
I think the key about Caparest is that it's a genetic inflammatory mediator. So what happens a lot of times, what is NF-kappa B? Again, it's a protein matrix that enters into the nucleus of a cell. It binds with the DNA. And through that process, we have a genetic inflammatory response. And the causes of that could be from so many different levels, from environmental to consistent food allergens that we're having every day. And so this was developed by Dr. Alex Vasquez, and if any of you have not heard his, he does webinars with Biotics. He goes through so much detailed information. This was developed by him, and it's a wonderful product to inhibit that genetic inflammatory response, and does phenomenally well. Even if you're eating a food, you might take 4 of these supplements prior to, and again, it's going to inhibit that genetic inflammatory response.
So another way to evaluate the body's ability to methylate is by what I told you previously, by checking homocysteine. Homocysteine is usually covered by conventional laboratory testing, and it's an inflammatory marker. The ideal number that we shoot for is 8. If people are above 8 or around, my level was 12 because I do carry the MTHFR gene also. What we need to do is bring that down by helping our methylation with the activated B folate. So we want to try to lower our ratio of the 2:16 hydroxy ratio because when it's elevated, it's associated with lupus. And this is another reason, as I said before, this is included in the micronutrient test, the SpectraCell test. When you order the SpectraCell test, it can include, you have to tell them that you want the MTHFR gene also, and that is for a minimal amount of money. If you go and just do the MTHFR through, usually insurance won't cover it, and if you do it through conventional labs, it costs like 400 bucks. It's very expensive. So it's really a good deal to get the SpectraCell micronutrient test with the MTHFR for like 195 or something. Other ways to support methylation besides the methylfolate plus is CME, methionine. These are also, and TMG, is other ways that provide our bodies with more ability to methylate. Other factors that can affect estrogen metabolization are obesity. Like I told you, the fatter a person is, the more estrogen they store, the higher the estrione level is in their body. So by just reducing weight can help decrease the risk of breast cancer, because estrione, as I said, attaches to the alpha receptor, and that causes cellular proliferation. Xenoestrogens are also a big culprit nowadays because of our environment is filled with pesticides that mimic and attach to the estrogen receptor and stimulate the estrogen receptor. Also, the stuff that we're injecting into animals and that we're eating, and the contaminants and plastics, those are all xenoestrogens. And I know just in my practice and seeing, there's a great increase in breast cancer and prostate cancer because of the xenoestrogens in our environment. And this needs to be paid attention to, and that's why I advocate, trying to not tell, especially when I was practicing in Arizona, because people would have water bottles in their car, the plastic water bottles, and with that heat, and that would just activate all that xenoestrogens in the water, and I'm sure that's a big culprit. Alcohol also can cause increased effects of estrogen metabolization and antibiotics. As I said, for obesity, the reason for this is because estrogen storage is in the fat cell. Also, the concentration of sex hormone binding globulins are decreased. So when we have a decreased amount of SHBG, that means we have more free estrogen, estradiol, available in the serum, which will cause more stimulation of the receptor, because it's the free estrogen that has the activation of the receptor. So obese people have they have more free estrogen available, therefore more stimulation to the estrogen receptors, and they also have more storage of estrogen in the fat, and also it increases the 16-hydroxy metabolism.
When somebody's losing weight, maybe even rapidly, do you see complications that come about in the hormones from the things that are stored in the fat that's now being released, or is it usually
Well,
not an issue?
Well, I think when they lose weight, you got to watch because that's also where we store all our toxins. So I see a lot of people have a rapid weight loss. You kind of have to watch. That's why I really promote more slow weight loss than rapid weight loss. Number one, they'll more apt to keep it off if they lose it more slowly. Yes, the dosage of your estrogen is going to change. So his question is rapid weight loss with obese women. Did I answer that appropriately? Good. Okay. So as I said, the xenoestrogens are a big problem. So there's 50 chemicals that imitate the estrogen, and pesticides and synthetic hormones that are fed to animals, plastics, even cosmetics have a lot of estrogens in them that we need to pay attention to, because this is what is contributing to the rise of prostate and breast cancer. Alcohol interferes with the body's ability to detoxify estrogen and increases estradiol levels, which increases the risk of breast cancer. So we can minimize the risk of breast cancer by getting rid of the xenoestrogens, trying to promote weight loss, trying to decrease alcohol, and also antibiotics. Antibiotics are found in foods. They may be associated with elevated risk of breast cancer because they alter the gut flora. And the gut flora we are finding now is important for many different things, because if we have overgrowth of bad bacteria in our gut, it's also going to impair, we're going to have low K2, it's going to impair the metabolization and the creation of a lot of vitamins, minerals in our gut. So maintaining a good gut flora is important not only to make adequate vitamins and minerals for us, it's also good for our immune system. 70% of our immune system comes from our gut. So our gut, number one thing that we need to first attack and treat and make sure it's balanced. And then after the gut, then the adrenals, thyroid, then the hormones. I sound like a broken record, huh? So again, measuring the estrogen metabolites, I do through ZRT labs, and it's with, they give you 4 different little urine paper strips that it's easy to do, and then they can tell you what way the patient is metabolizing their estrogen. And because we want them to metabolize down the 2-hydroxy, if we find they're going down 16 or 4-hydroxy, they're at increased risk of breast cancer. And if you can't solve that with supplements, you may want to really reduce their level of hormones or alter it. Make sure you prescribe more estriol instead of estradiol, so you're not creating more harm to the patient. Okay, now we get to the questions that you had previously about routes of administration. And yes, hormones can be given orally, topically, injections, patch, and there's even pellets. So when you give estrogen orally, as I said, it goes through the liver. So you're going to have effects in the clotting cascade, and it's going to cause an increase in blood pressure. It increases triglycerides. It increases the bad guy, E1. It can cause gallstones. It can lower growth hormone. It can increase the prothrombic effects, like I said, because it increases the clotting factors. So that's why I never give it orally. And this is scientifically shown. And shame on me, because in the past I gave it orally. So that's a mistake. But we learn from our mistakes, and we need to change the way we treat our patients as we evolve and as we learn things and as we stay current on the recent literature. It also, when you take it orally, it increases serotonin metabolism. So if our serotonin it goes down, then they get depressed, and we're creating another problem. It also increases CRP. That's an inflammatory indicator. And we know all chronic disease is caused by chronic inflammation. Our goal is trying to bring down our homocysteine, bring down our CRP. So again, I think if you give estrogen orally, you're creating more harm to the patient. It also increases carbohydrate cravings, which we don't want to have. And end up diabetic. So in my opinion, always give estrogen transdermally. Progesterone loss. If we have, you're going to see a lot of progesterone loss. And the reason for a lot of progesterone loss is because there's so much stress. So in the hormone cascade of things, it's called cortisol steal. If you're stressed, you're going to go down the cortisol pathway and you're going to be low on progesterone. So I see a lot of women who are low on progesterone and they're actually estrogen dominant. And it will cause symptoms like anxiety, depression, irritability, mood swings, insomnia, pain, inflammation, hypersensitivity, nervousness, headaches, weight gain, decreased libido, and decrease in your HDL. Causes is cortisol steal, as I said, low LH, increased prolactin production, antidepressants can lower your progesterone, excessive arginine consumption can lower progesterone, sugar can lower progesterone, saturated fats, deficiencies in the vitamins, and also decreased thyroid hormone can lower your progesterone. Synthetic progesterones, like I said before, are called progestins. And the synthetic progesterone that commonly a lot of conventional doctors use is called Provera, or medroxyprogesterone is the other name. So those are the ones that you want to stay away from. And the reason why you want to stay away from the progestins is because it doesn't hook on the receptor site like natural progesterones. So it doesn't give you the benefits that natural progesterones do. And it causes an increase in appetite. It causes weight gain, fluid retention, irritability, depression, headaches, decreased energy, bloating, breast tenderness, and decreased sexual interest. So these are the reasons why we stay away from Provera. Other side effects of progesterones also acne, hair loss, insomnia, nausea, interferes with the body's own production of progesterone. It doesn't help the balance with the estrogen, so it doesn't even help you with the synergistic effect that it has. And it remains in the body longer. It even can cause spasm of the coronary arteries. And so in the WHI study, it's the medroxyprogesterone that causes all the heart attacks that they had to stop the study early. Because the early trials, they continued on the Premarin arm of the study and stopped what we call the Primpro arm because the big culprit was medroxyprogesterone. It's bad stuff. No one should be on it. Other side effects. Progestin increases breast cell replication, growth due to the stimulation of the estrogen receptors. So again, you want to stay away from it. More side effects. Gosh, it stops the protective effect of estrogen. It may make symptoms of progesterone loss worse. It increases LDL, all the stuff we don't want. Decreases HDL. It protects only the uterus from endometrial cancer. It counteracts many of the positive effects that estrogen has on serotonin production. The effects of natural progesterone is totally different. Now we've got something that's chemically similar to what our own body produced. It attaches to the receptor site appropriately, and it helps balance the estrogen. It leaves the body quickly. It helps improve sleep when it's given orally. It works on the GABA, it stimulates the GABA receptors in the brain when it's given orally. And it creates a natural calming effect. It will lower blood pressure. It helps the body use and eliminate fats, and it lowers cholesterol. These effects aren't seen with the medroxyprogesterone or the Provera. It increases scalp hair. It helps balance fluids in the cells. It increases the beneficial effects of estrogen on the blood vessels. It increases your metabolic rate. It's a natural diuretic. It's a natural antidepressant. It's also anti-inflammatory. So more benefits of natural progesterone is has been shown to help with osteoporosis, and it helps stimulate new bone. It enhances the action of your thyroid hormones. It improves libido. And it also helps restore proper cell oxygen levels. Natural progesterone decreases the risk of breast cancer. This is a study that was done that showed that everyone should, the benefits of being on a bioidentical progesterone will decrease the risk of breast cancer in 80% of postmenopausal women after using it for 8 years. It was found that women who used estrogen in combination with synthetic progestins had a 69% increase. What a huge difference. Women who used progesterone in combination with estrogen had no increased risk when it was bioidentical. So again, stay away from the synthetic stuff and stay with the
We do have a Nature progesterone back through here, so it's in a cream. For those of you that want to try some here today, you can do so.
Okay.
It's a BRC. It's actually it's not a BRC product. It's just a unique product that we have here within Southern California.
Okay, great. Okay, so then we're asking about the symptoms of when you would give, you were asking as far as not taking progesterone, giving estrogen and not progesterone, but this slide will tell you what happens when you have too much progesterone and not enough estrogen. So again, it says, some people read Dr. Lee's book and he just promotes progesterone, and so they just come in and just on progesterone and then they throw off the balance. And these are symptoms that can result in too much progesterone with not enough estrogen. Symptoms of too much progesterone, again, it can elevate cortisol, increase appetite and carbohydrate cravings. It relaxes smooth muscle in the gut, so it can also cause bloating, fullness, and constipation. I need to tell you that when you do bioidentical progesterone, if it's in the cream, don't put it on the gut for this reason, is because it relaxes smooth muscle. So I'll talk about that later about how to apply the topical creams. But if your topical cream has progesterone in it, don't put it on the gut because it will slow down bowel motility. Now, testosterone is mainly belongs in the class of male hormones called androgens. But as I said before, estradiol is produced is a metabolite of testosterone. In men, testosterone is produced mainly by the testes, with a small amount made in the adrenal glands in the brain. The brain's hypothalamus and pituitary control the testosterone production. The hypothalamus instructs the pituitary gland on how much testosterone is produced. So we do have the HPA axis that we have to pay attention to when we're testing, because there could be a problem with the hypothalamus stimulating the end organs. Testosterone is converted to estradiol. Again, I mentioned this before, through aromatase. And as men age, the estradiol levels to testosterone increase. Elevated estradiol to testosterone increases the risk of prostate cancer and BPH. It is not only the decline in testosterone, but also the increase in estradiol that cause the symptoms of andropause, which I'll talk about later. So in women, the ovaries produce most of the testosterone. The adrenal glands do produce some of them. Women's total testosterone levels is like about 1/10 to 20th of what men's are. High testosterone levels can be seen in women, and that's what we call polycystic ovary disease, is when the adrenals are producing too much testosterone and throwing off the balance and causing women to be amenorrhea when they have too much testosterone. Also, they'll have more acne and deepening of the voice, and it can also contribute to infertility. So there are ways to balance that also. Testosterone, the benefits of testosterone is increasing sexual interest. It increases your emotional well-being. It increases muscle mass and strength. It helps maintain memory. It helps skin from sagging. It decreases excess body fat. It helps maintain bone strength and elevates norepinephrine in the brain, so it has a tricyclic effect. So again, that's why I like to balance all my women with all three: estrogen, progesterone, and testosterone, if needed. There are 20% of women who are postmenopausal who don't need testosterone. So the only time I replace that is if I see that they're deficient. So again, you start out and you test. So some postmenopausal women don't need testosterone because they produce enough from their adrenals. Symptoms of low testosterone are the opposite of what I talked about. It causes weight gain, it causes muscle weakness, it causes low self-esteem, decreases your HDL, it thins out your skin, it causes droopy and sagging cheeks and thin lips and anxiety. And your memory is just not as sharp. So testosterone is an important component to the hormone replacement therapy of women. What causes low testosterone? Because a lot of times if a patient comes in with low testosterone, you always want to look at the root of the problem. What's causing this? And reasons: menopause, chemotherapy, childbirth, adrenals. Your adrenals are burned out. That's why it's important. Don't just jump to correcting the testosterone and giving testosterone replacement, because sometimes if you treat the adrenals first, the testosterone level will come up and it doesn't need to be replaced. Depression can cause it, psychological trauma. Birth control pills definitely drop your testosterone and your libido. Testosterone replacement should be given transdermal. This is another one that shouldn't be given orally. It's been shown that it's been associated with an increased risk of liver cancer. If you use testosterone transdermally, you need to rotate the sites that it's put on, because otherwise you're going to cause unwanted hair growth in different areas. And in order for testosterone to work well, you have to have adequate estradiol. So again, just don't prescribe testosterone. You need all three. Without enough estrogen, testosterone can't attach to the receptors in the brain. And if testosterone is given alone, it can increase plaque formation. Yeah?
So in regards to estrogen with testosterone, I'm assuming you're only recommending that for women, correct?
Yeah, so with men, I would not give them estrogen because usually they have enough of it. If they were low, then I'd consider it, but I've never seen that. So in men, it's primarily testosterone that I'm replacing. And I'm trying to prevent them I'm trying to lower their estradiol because the majority of them will have high estradiol. And then we do that with the aromatase inhibitor. Great question. Okay, other ways to raise testosterone is decreasing your calorie intake and increasing your protein in your diet and taking amino acids like arginine and leucine. B Vital also has been shown to raise testosterone. That's a biotic supplement, and I will go into that later on. But it has been shown a way with herbs to raise testosterone in 100% of men that were participating in the clinical trial. Glutamine, getting enough sleep, exercise, losing weight, reducing your stress, taking zinc, like we said, that's vital in making sure that helping your testosterone levels. This is B Vital that I alluded to that will help raise 100% of men had improved their testosterone levels. And this is 750 milligrams of Peruvian maca root and 50 milligrams of velvet deer antler. And this is a biotic supplement that you take 1 tablet twice a day. It's not recommended for children, of course, and pregnant ladies.
This works just through the hypothalamic pituitary axis, is that correct? Or does it have a direct stimulative effect on the testes?
You know what? I got to ask Paul because I don't know that answer.
I think it's a correct. This is not working. So it's a great question. So we're going to go through in a couple minutes the role of the pituitary and hypothalamus with the production of testosterone, and that'll be with our cytosine PT-HPT. I'll just talk about it now real briefly. We have our cytosine lines, which are our neonatals, which are newborn calves with high levels of RNA and DNA to regenerate and support organs and glands. There's a direct link from the pituitary gland into sex organs, and so that's where we want to be able to look at if we have a dysfunctional pituitary and hypothalamus. So B Vital is actually working direct link into the increase in production of testosterone, and that's what they before and after treatment, and this product brought it up in that.
But through the hypothalamus and pituitary?
No, we're not through the hypothalamus and pituitary. Right. Okay. Good. And then not to keep, next slide on this, not to have a product here for females, Gillian.
Well, that doesn't,
Next slide.
it can increase testosterone in females also.
Yes, it does.
But we also have a product called Biodrive, which
Next
increases
slide.
desire for women. We couldn't have one for the men if we don't have one for the women, right? So that's
And
just
the
for
studies on,
women.
and the studies on one twice a day.
Yes, that's correct. Anything else?
Yeah.
Quick question on
Sure.
dosing with testosterone. Do you cycle it on and off with men?
No, I don't. Women, sometimes people say that it'll help decrease the receptor site saturation and prevent downregulation. So in women, they say, 6 days on, 1 day off. Men, a lot of times they just do the injections every 10 days. So I haven't seen, I don't, 10 days, topically, no, not with men. I haven't seen studies to support that you should take a holiday off of that,
I'm
as
just
far
wondering
as.
about increased production of sex hormone binding globulin with the
Oh,
use of
that's a good question. That's a good thing. That's a good consideration. But no, I don't. On the men, I just have them on continuous testosterone. I don't know if there's any studies to support that, but I'll look into that. That's a good insight, though. All right, Biodrive. This is for females, and this is if someone has low libido. This is another way, instead of giving them testosterone, if they're totally anti-hormone and they're having problems with their libido, Biodrive is an excellent alternative. And you take 2 capsules daily before noon, and it's not recommended during pregnancy or lactation. Symptoms that you're overdoing the testosterone are anxiety, depression, fatigue. I think most of the people on the freeway here have the road rage. Or I'm like, you got to get your testosterone checked, buddy, because as they cut you off. But hypoglycemia, agitation, anger, facial hair, acne, insulin resistance, weight gain, hair loss, or unwanted hair growth, increased in heart disease when you have too much testosterone. So this is really important. You got to test. Just don't give your guys testosterone or women and send them on their way, because if you get super physiological doses, there are consequences of that. It's all about balance. We need to balance the hormones, because if they're overbalanced, you could be causing harm.
If you're having to choose between using testosterone for a woman, Be Vital, or Biodrive for low libido, what's your favorite, and how do you choose between which avenue you're going to go?
That's a great question. His question is whether I use testosterone, Be Vital, or Biodrive for women if they come in with the complaints of low testosterone.
No, low libido.
I mean low libido. Okay. So first you want to check their level, right? Because there's there's a lot of reasons for low libido. It may be because they're married to a jerk and he's, and it's like, so you can't just assume, so I'd first want to test to find out where their levels are. And then, if they're menopausal, usually, if they're low levels, I usually go to testosterone, But if it's someone who levels are within an okay range, then maybe Biodrive, But Be Vital, the other one, I would only use if their testosterone was low, because that could increase. Yeah?
And say you had a woman who's 6 months post-delivering a baby and she has zip libido. Are any of these safe? And she's breastfeeding?
I'd have to defer that to, I think Biodrive, is that it'd be okay. Yeah, but a lot of times it could be because of vaginal dryness. Estriol would be good to use too, if they have problems with that. Yes, been there, know that, yeah, okay. All right, great question. All right, so we want to avoid estrogen dominance because this is a condition where we give too much estrogen. And a lot of people are estrogen dominant, and the reason being is because a lot of us are stressed. And so when we have an increased stress, we get the cortisol steal, and then we lower the amount of progesterone. So estrogen dominance is especially also prevalent because of the xenoestrogens that I alluded to prior. And so we need to try to prevent that. The effects of estrogen dominance, too much estrogen related to the amount of progesterone we have, can cause a lot of problems. It can cause fibroids, weight gain, water retention, PMS, migraines, sluggish metabolism, mood swings, heavy periods, irregular periods, infertility, cancer. So, and it's frequently seen, especially towards the end of my practice, I would see a lot of young girls starting their menses at a much earlier age because of all the antibiotics and stuff that they're putting in meat and in milk, you know, so, and the xenoestrogens. So I would get 6- and 7-year-old poor little girls already cycling, which is devastating. And then it's because of our environment, and we got to make sure our patients are aware that what milk does. There's a lot of stuff in milk that is promoting with the antibiotics and the xenoestrogens. So other symptoms of estrogen dominance, it can contribute to autoimmune disorders. It can contribute to allergies, gallbladder disease, excessive fat in your hips and thighs, and early onset of menses, hypoglycemia. So it's really important. It's all about balance. Again, we need to pay attention to that. What are supplements that we can use to help with estrogen dominance? We can use chasteberry, chrysin. These are aromatase inhibitors, B-complex, and TMG has been shown to help neutralize the homocysteine. I3C and DIM, these are things that will help when we're estrogen dominant to help us metabolize down the healthy pathway so we don't have an impact of causing an increased risk of cancers. Myomin I use a lot in my practice, and I think it's really helpful in women who come with heavy periods or who have fibroids or who are fat or, you know, that you know. And sometimes I just put them on Myomin when they're not menopausal and they're estrogen dominant, and that helps them because in the olden days, another mistake I'd make in my professional life, I just put them on birth control pills. It's like, oh, your periods are heavy, here, take a pill. And now those are synthetic progestins, you know, and that's not what I would do nowadays. I would put these women on Myomin. Yeah?
Would males present with this fat deposit on their thighs and hips, like from the...
Yeah, because when they go into andropause, they're mostly estradiol, and you see the man boobs and the bellies, you know, and the fat hair. You go to the gym, you just say, hey, buddy, you got to get some testosterone. I can tell. You can, when you see enough people, you can tell because, yeah, men's physique change as their testosterone, as they age, because they'll get the bellies just like we do because they have too much estradiol in the man boobs. And then they lose their muscle mass. You can definitely tell the men that aren't taking testosterone.
A lot of, young males.
Yes.
With breasts.
Yes.
Physically like.
Yes. Yes. Well, yes, and they should be tested because a lot of young males are getting low in testosterone because of all our xenoestrogens and what they're eating. And they need to be tested and they need to be replaced. But not with testosterone because it can cause low sperm count and it can also cause testicular atrophy. So later on I talk about HCG, which is what I would utilize in young males with low testosterone.
For testing, is there a certain time of the month that's best to use these ZRT tests for the ladies?
For the ladies, if they're cycling, you want to test between day 19 to 21 because in the first phase, that's the follicular phase, and that's where estrogen's predominantly produced. But you want to see their level of progesterone, and progesterone's produced in the luteal phase. So, and day 14 is when we ovulate and we get the spike of estrogen. And then the corpus luteum produces progesterone. So you'd want to make sure we're getting adequate progesterone, right? So if you test on day 1, you're not going to know how they're producing their progesterone. So that's an excellent question. And yes, you need to test women that are perimenopausal or who are still cycling on days 19 to 21. Okay, great question. Okay, so prevention of estrogen dominance is balancing the hormones and not with progestins, and we talked about why not. Also, as we said before, reducing stress and decreasing the chemicals and pesticides, improving their diet, exercise, fiber supplements, flaxseed oil is a good way. Okay, now let's talk about dosing. Okay, so what I commonly use is Biest. Biest is a combination of estradiol and estriol. I do not use Triest, and the reason that's including estrione. We don't want to replace estrione because, as I said, that's a hormone that's usually increased in menopausal women anyway, and estrione has an affinity to attach to the alpha receptor, which causes cellular proliferation and increases the risk of breast cancer. So the only hormones I recommend that you replace is estradiol and estriol. So now that we have this, then you ask, well, how do I know how much to use or what to use? If I have a very obese patient, I will use more. We know that they have more estrogen on board because it's stored in the fat. Then I'd maybe use an 80-20, 80% estriol, because as I said before, it's a weaker estrogen, and 20% of the estradiol. So if they have the MTHFR gene and they have problems with methylation, you don't want to overburden them with a stronger estrogen like estradiol, so I'll switch the ratio. I'll do 80% of estriol, which is more protective, and 20% estradiol. Now, if people are converting that's more like if they're on synthetic estradiol or estrogen. If they're on synthetic estrogens, then I would maybe switch them over to a 50-50 ratio. Or if they're thin, then I go with a 50-50. So that means 50% estradiol with 50% estriol. Triest, as I said, I never use anymore because it increases the risk of breast cancer and also cardiovascular disease. I was always trained, start low, go up slow. So, because if a patient comes in, you don't want to overshoot them. And so this is kind of the low doses that I start out in 0.5 milligrams, and 80-20 that would provide you with 0.4 milligrams of estriol and 0.1 milligrams of estradiol. A medium dose would be 1 milligram. A high dose would be 1.5 milligrams. Just so you know what is the average dosing and how to start and begin your patients. Now the placement of the cream, and I talked about this because a lot of doctors will say, oh, put it on your forearms and just rub it together. Well, what happens is if you want it to, you need fat for the hormone to slowly disperse among your body. If you put it on the forearm, it's going to go straight into the blood. There's no reservoir of fat. So if you're going to do the forearm dosing, you may, and if they do it in the morning, she may get hot flashes at night. Instead of increasing the dose, it would be better to maybe do 2 clicks in the morning, 2 clicks in the evening if you're doing it on the forearm. But another way to get around it is putting it on a fatty area. So either on the butt cheeks, or if they don't have progesterone in the cream, you can put it on the abdomen. And so the BID dosing, if it's on the forearm, you want to rotate sites, because if it has testosterone in it, then you don't want the unwanted hair growth. And as I told you before, you want to avoid the abdominal area if it has progesterone in it. Progesterone dosing, this is what I had talked about before also, is that if you have a patient who's having trouble with insomnia, anxiety, or if then you want to give the progesterone orally because it will cross the blood-brain barrier, attach to the GABA receptors, and help them with those symptoms. If that's not a factor, then you can give it in a cream. I've seen this a lot. patients will come into me with 100 milligram progesterone cream, you know, and mixed in with their bias. And I'm like, oh man. So I think people need to realize that the doses of progesterone with oral is different than the creams by a lot. So remember that if you're using a topical cream of progesterone, the dose range is between 10 to 20. If you're doing an oral progesterone, it's around 100 to 200 milligrams. Progesterone dosing for perimenopausal women is best to do in the luteal phase because that's when they normally produce progesterone anyway. And I usually say 10 days before their period, you know, roughly. And if they have PMS symptoms, a lot of times progesterone will help during the 10 days before their period. The dose range, if it's given orally for a perimenopausal, could range between 25 to 100. If you're giving it as a cream, it's between 10 to 20. And this is what you asked before, when to test. Test between 19 to 21 days during the cycle. Salivary testing is needed for checking on if you're doing a topical dose.
Why is that?
The reason being is because when you give progesterone topically, it will rapidly go into the tissues and will only stays in the serum very rapidly absorbed into tissue. Limited amount are in the serum. And so the salivary testing is reflecting of what's in the tissue. And so that's why you want to, a lot of times when people just follow serum levels, they will overshoot their progesterone dose because the serum is not a good reflection of what is actually in the tissue. Okay, so here we go. We get excessive amount of progesterone can cause symptoms too. So it's all about balance. And you know, when you're doing the perimenopausal or the PMS people, you got to go low because every cycle they're going to produce different amounts of progesterone because it's dependent on the corpus luteal cyst. And sometimes they'll develop a healthier corpus luteal cyst and they'll have normal progesterone levels. But the next cycle, they're low on progesterone. So, you know, it's better to go low and not overshoot it because if you overshoot it, they're going to get sleepy. And that's a lot of times why if you're doing the oral progesterone, you tell them to take it at night, you know, because it helps them sleep. But also if they take it in the morning, you avoid the sleepiness that they could develop. And if you overshoot the progesterone, they can get bloating and water retention, depression, and breast tenderness. Okay, now we talked about that you can get pharmaceutical. You know, the Vivel dot is bioidentical, that's estradiol only, and Prometrium you can get at the pharmacies, and that's bioidentical progesterone. Now we talk about compounding pharmacies. Compounding pharmacies are not all created equal. There's a lot of compounding pharmacies out there, and you really need to know what you're dealing with because you got to make sure they're accredited. You got to make sure that they independently test their hormones. And I've seen in my experience, I'll have a patient who I have them on their hormones and they're doing great. And all of a sudden they call and they're like, oh man, I'm having hot flashes again. I'm like, well, why is she all of a sudden having hot flashes again? And then first thing I do, I call the compounding. Did you change the base in so-and-so's recently? Because it wouldn't only be one person, it'd be like 10 calls. Everybody's got hot flashes and it's not hot, you know, outside. So, and the reason being is because they changed the base without telling me. And they will do that to you. And if you get a cheaper base, it's going to affect the absorption of the hormones in the skin. So now specifically, so I can avoid that problem, when I write the prescript for bias, I specifically say I want it in Versabase because otherwise I'm going to get all those phone calls. Versabase is known to have a great delivery of the hormones into the skin, and I usually like the click system. There's a
Can you spell that Versabase?
Oh, V-E-R. I think
Okay, thank you.
I think I talked about it. Yeah. So Versabase is what I use, and I like, okay, so sometimes it comes in a jar, or some hormones come in a jar, and they have this little scooper thing that you put on, and it's like, well, God, I'm getting it all over the place. And not only that, you know, I just think just putting your fingers in or whatever. So I like the click container, and they have this click container, and you just click the bottom of it, and the hormone comes on the top. You don't even have to touch it, so it decreases the incidence of transference, because if you get it all over your hands and you touch your kid or your husband, you're transferring the hormones, and it can transfer over 12 hours after you apply it. So the click container, it has 4 clicks. You take the top off, it has 4 clicks. You never touch it, and you just rub it on the area that you need. And I think there's less transference, there's less contamination of bacteria when you have an open jar and things like that. So I specifically, when I write all my prescription for Biest, I specifically say I want it in VersaBase and I want it in a click container. So there's, you know, that's my personal preference, and I told you the reasons why. But so I only use accredited pharmacy and then the click containers. Bioidentical hormones, these we kind of already talked about, the oral, topical creams, gels, sublingual, vaginal, suppositories, pellets, and sub-Q injections. So do I don't use pellets, and the reason why I don't use pellets is because you can't get them out. Okay, so I get a patient, you got a pellet in them and they get breast cancer. You know, it's like, okay, so now I got this fueling their breast cancer, I can't stop it. So I wasn't a big fan of pellets. There's a lot of people who use estradiol and testosterone pellets, and that's the reason why I don't. And I've seen consequences of that, and it's just a bummer because they come in here hemorrhaging, or they got acne, and they got road rage, and these are women on testosterone pellets, because the doctor overshot them, and so now I'm like, how do I get rid of this, you know? So it's just something that I don't use just because you can't titrate the doses as well, and you can't get rid of it. But a lot of people love them, but that's just my personal preference. So we need to, as I said again, don't replace, you want to check the adrenals and treat the adrenals first, because it can change your dose of your hormones. Fitness and nutrition regimens help balance the hormones. We kind of talked about that. And also, that was a big mistake I made in the past, is I lost my mind-body connection. I lost all awareness because I was running around delivering so many babies and didn't pay attention to myself, and that's how we get sick too. So it all contributes to the condition. Okay, so I have one little case that I want to talk about. This is a 57-year-old G0P0 who was on conventional HRT since 39 because she had premature menopause. She tried various regimens of conjugated equinine estrogen, that's our favorite Premarin, and synthetic progestins, and lo and behold, she felt terrible. So some nice doctor, well, the GYN stopped the HRT, and then she saw an endocrinologist. Obviously, this endocrinologist wasn't skilled with hormones because he started her on Triest and progesterone. But at least it was bioidentical. But man, look at the dose, 9 milligrams, you know. Remember, I say start out slow and go up, you know, so he way overshot it. At least he got the progesterone dose right. But hey, she felt better, you know, yeah, she got a ton of hormones now. But still had brain fog and no libido because he didn't even add testosterone. So the mistakes are he gave her Triest, overdosed them, didn't add testosterone, but he did do good by giving progesterone, and at least they're bioidentical. So these are her saliva results. You see that everything's elevated, and you see her progesterone and estrogen and ratio is off. So then we look at her cortisol, and we see her 4-point salivary cortisol showed that her adrenals burned out. She was low on cortisol in midday. Her thyroid was normal, but her T4, T3, and she had high reverse T3. Her TSH was okay. Her antibodies were negative. And we would give thyroid hormone at this point. We got, as I said, you got to fix the adrenals first. So what we did was wean her off her Triest over 6 months, because you can't abruptly take it away or else she'll shoot you. And you want to change her to Biest to 80-20 combo. And we slowly decreased her 8 milligrams until she got 1 milligrams. And then we also help, because she's on such excessive doses, you got to make sure you want her to metabolize down the 2-hydroxy pathway. And we do that by giving her I3C or DIM. And then we added 1 milligram of testosterone to the Biest. And with her adrenal support is with a desiccated extract with ABD5+, and also gave her some vitamins and change in lifestyle and diet. ABD5+ is good for phase 3 adrenal fatigue. Now there's 3 stages of adrenal fatigue. Stage 1 is when our cortisol goes up. Our DHEA may be normal or slightly elevated. And in phase 2, we see our cortisol goes down. And then in stage 3, we see our cortisol and our DHEA is down. So depending on what stage of adrenal fatigue is how we go about supplementing. If we're in stage 3, they may even need Cortef, but an alternative is the Biotics product ADB5+. This is an excellent product. It's a desiccated adrenal gland, but it also has the vitamins, the B vitamins that we burn out so quickly when we're stressed out. And it also has vitamin C, and this is what I would do when they're in stage 3. And then once they're, and I do that probably for about 6 weeks or so. And once I try to get them feeling better, then I'll switch to ADHS, which is actually more of the herbs. And maybe you didn't give me a slide on that.
Next one.
Oh, is it the next one? Okay. Hey, there it is. Okay, so in phase 1 of adrenal fatigue, usually I go to ADHS. This is also a great product because it will help support your adrenals by herbs and also replacing the vitamins that we burn out so quickly with our stress. Okay, so after we did all that, she was feeling great, and her salivary levels look a lot better, and the vaginal dryness improved and things. She was a happy patient. So now that we stabilized her adrenals, her thyroid, she was still low, and so we did give her some GTA, which is a glandular thyroid. We talked about that Biotics product already. And you may need to increase or retest in 3 months, and you want to retest 4 hours after taking the dose. This is a chart that Paul put in, and it's just to help you do the conversion from to the Biotics product.
Everyone has the chart in the back of their notebooks, which they can utilize with this, and we'll review this in a little bit.
Okay. Okay, GTA and GTA Forte are also Biotics products. This is an option for people who are hypothyroid. It contains desiccated porcine glandular product to help you with your supplement for hypothyroidism. And then along with the Metastim. Metastim is, again, will help with the conversion with the inactive T4 to the active T3. And we will identify if this is the cause of their hypothyroid, because we're all going to get our SpectraCell test first. And yes?
Is the reason to test 4 hours after GTA is going to cause a false TSH reading?
Yes, exactly. His question was, testing, if you test right after taking GTA, can it affect your TSH reading? And yes, it can. So it's recommended that if they take GTA, do the test at least 4 hours after taking the dose. Okay, so take-home points on Lady SG is that physiological dosing is important to achieve optimal balance. You don't want to do super physiological dosing because you're going to increase her risk of side effects. You want to assess the adrenals and thyroid. You want to restore the adrenals and be patient because it takes a while to get the adrenals up to par. And you want to wean off slowly with the HTR so she doesn't shoot you when she's on super physiological doses. And you also want to promote lifestyle and dietary support. The interaction with cortisol with the reproductive system, we kind of talked about. The cortisol steals. Stress will decrease your progesterone. Okay, so don't forget the adrenals will interact with progesterone. The adrenal surges will occur with stress and can block the progesterone receptors. So it's not only that it inhibits and lowers the production of progesterone, but it also blocks the receptors. This can prevent the progesterone from being used effectively in the body. And if someone is under a large amount of stress, more cortisol is produced because of progesterone, called cortisol steal. Cytozyme F is another biotics product that could be an option if someone did not want to be on hormones and to help support their ovaries. And this can be used and combined with other glandulars. Equifem, if someone said, nope, I don't want hormones, but I got these darn hot flashes and I hate them and I want something done for them. Equifem's a great go-to because it also provides them with a multivitamin along with Don Quai and some things to relieve their hot flashes and maybe PMS symptoms if they're not menopausal. Cytozyme PT, this will help support the pituitary hypothalamus axis, and this is another option if you see that they're having a disruption along the axis. Okay, so now we get a little bit for the men. Yep, they have problems too. So they get the andropause. So yeah, they get those mood changes too. You know, they always say, oh, you must be PMSing or you must be menopausal. But they do have andropause. They get irritable, they get reduced libido, potency, and depression. And the expected benefits from testosterone, which really helps men as they go into andropause, if you replace their testosterone and get them to the normal reference range again, they'll feel a lot better. Their mood will be better, libido will be better, they'll have more erections, more muscular stamina and strength and fewer naps, and they'll feel like they're 20 again. So you can't ignore them. I think there's a lot of benefits with replacing testosterone in men. There's studies that say that it helps cardiovascular, it helps lower the risk of diabetes. So how do we replace them? Well, we can do creams, pellets, or injections. The creams, you just have to watch as far as transference again. The cyprinate, testosterone cyprinate, is an injection that I usually do every 10 days. Pellets are an option for men, which isn't as bad as for men than for women, but again, sometimes if you overshoot the dose, you can't adjust it as well. HCG is used for younger males that have low testosterone because you don't want to give them testosterone because it can cause testicular atrophy and lower their sperm count. So a way to get around that is by giving HCG. HCG is a subunit that mimics LH and FSH. You've got to check their LH and FSH their levels, because if LH and FSH is elevated, it's not going to work. So if you have a young male with low testosterone, check their LH and FSH. If they're in normal range, then you can treat them with HCG.
Question. So androgel is like the popular, you're not talking about, are you talking about androgel?
Yeah, I don't use it, that because it's so expensive. Androgel is a pharmaceutical testosterone that it's very expensive. A lot of insurance don't cover it. And in this case, pharmaceuticals at the pharmacy, it's more expensive than doing a compounding.
It's the bioidentical.
Yeah, so I usually just use the bioidentical. Yes, you don't.
When you say the risk factors, there's been so much that the legal industry is just camping out on this with androgel as far as strokes and heart attacks and
Right.
things like that. Is there going to be a difference in the androgel versus the bioidentical? Like the same thing with the compounding for the female hormones?
Right, right.
Is there a difference? Or?
That's a great question. So you're asking if androgel versus compounding hormones, if they have added
Reduced risk factor.
I think the risk factor is the same.
Risk factor.
You know, so between the two, yes.
Thank you.
So these are testosterone therapy. You don't want to overdose because it can be very harmful. So you don't want to do super physiological dosing. Common side effects if you do overdose: acne, oily skin, body hair, testicular atrophy, male pattern baldness, nipple sensitivity, increased aggressiveness, and polycythemia. So that was a big reason why in the initial blood work you want a CBC before you put men on testosterone, because I have seen their hemoglobin hematocrits go up, making their blood thicker, and that could increase their chance of a potential stroke. So you got to make sure they're not getting polycythemic. If they are, then you recommend that they donate blood and follow up with the blood work so you don't cause more harm. Other common side effects of this must be, if you overdo it. So if you overdo your testosterone, you can also get loss of sex drive. And I had one guy, he thought, oh gosh, I still don't feel good. I'm going to give more. I'm going to give me something more. And what happens, there's downregulation with testosterone. So, you know, he's at the curve, but he was over on the other side. So he was presenting with symptoms of low testosterone and actually had too much. So you can't go by just their symptoms because of the downregulation. So that's an important thing to consider because you just don't want to add on more hormones. And that's same with women. You know, sometimes there's downregulation with the estrogen receptors. So you got to test. So other things that can happen if you give too much testosterone is rage and tendon rupture, liver toxicity, gynecomastia, severe BPH. So when you overdose and it causes acne or anger issues, of course you want to just decrease the dosage and treat symptomatically. Polycythemia, as I said, you want to just tell them to go donate some blood. If they have high estrogen, as I said, testosterone is broken down to estrogen by the enzyme aromatase. So in order to prevent the guys from getting the man boobs, you got to give them an aromatase inhibitor and watch their estradiol level. Because I've had men that had that problem. So a lot of times I'll mix progesterone's an aromatase inhibitor, or chrysin, or an estatol. I'll talk about some of those. So to decrease the dose of estrogen if it's too high. Okay, and then so testosterone can go down to estradiol or it can go over to DHT. DHT is a bad guy. It's going to cause them to be bald. It's going to cause them to increase their prostate cancer and for BPH. So you want to watch the DHT levels. And to do that, that's 5-alpha reductase is the enzyme that converts testosterone to DHT. So we want to block that so they don't produce too much DHT. And we block that with things like saw palmetto, and Biotics have a product, Palmetto Plus Forte. And then also zinc will help too. And these are known to be aromatase inhibitors. Other aromatase inhibitors, you know, like in females, you can use spironolactone as an aromatase inhibitor. Metformin is also an aromatase, not an aromatase, a 5-alpha reductase inhibitor. So you got to watch PSA levels, because if they're going up, you don't want to have them on testosterone therapy if they have prostate cancer. So there's no benefit as far as look for more other causes of their symptoms than if they're not feeling better. So aromatase, again, I sound like a broken record, but hey, It's okay, maybe you'll get a take-home message then. Aromatase inhibitors, aromatase is estrogen, is testosterone to estrogen, and it's located throughout the body that does this conversion. The aromatase enzyme is found in the adrenal glands, ovaries, placenta, the Sertoli Leydig cells of the testes, the adipose tissue, the brain tissues. Signs and symptoms of testosterone converting to estradiol are man boobs or nipple soreness or mood swings or crying, water retention, urinary retention. So you make sure you check the estrogen levels on everyone prior to starting the therapy just to see where your baseline is. And make sure you monitor your estrogen levels while you're on therapy, especially if they're symptomatic. So then you have to think, well, when do you retest? How do you do this? Well, with the half-life of testosterone is in the serum is about 2 to 4 hours. So you definitely have to time it with the dose, depending if you're doing topical or if you're doing injections, because it definitely will reflect in your levels. So you need to know when their last dose was taken. And ideally, you want to check, 12 to 18 hours post-application with injections. The total goal is to have between testosterone level between 500 to 800. Injections peak after 3 to 4 days, so you'd like to ideally test them, their testosterone level on day 4 to 5 post-injection. And the goal is really to make sure that you're not exceeding supraphysiological doses because there's a lot of side effects. So after initiating therapy, follow up in 3 months, and then I check every 6 months thereafter. During the follow-ups, I inquire about their compliance and monitor to their side effects and discuss, how they're feeling. Because you just don't go by laboratory values only. You want to go on the clinical symptoms too. Okay, so the ways to, the things that I test, as I said, when you give testosterone, it can cause polycythemia. It could potentially elevate liver enzymes. You want to make sure the PSA is normal. And the goal for your testosterone therapy is between 700 to 1200. You want to check the estradiol and the DHT so they don't go bald and they don't yell at you for that, or you don't increase the risk for prostate cancer. Because if you see elevated DHT, you can block that with saw palmetto products. So natural treatment for elevated estrogen, again, aromatase inhibitors. These, the herbs that you can do are chrysin, I3C. Those will naturally help you block aromatase, so help you stop increasing your estradiol. Some people say that you should just go with pharmaceuticals instead of the herbs. They say the herbs don't help as well. I think in my experience, it's mixed, and I think it just depends upon the levels in the patient.
Question?
Yeah.
In regarding to the male patient, this is such a controversial question, so I don't know if you'll be able to answer it well. But what I've heard as far as the 5-alpha reductase inhibitors, that as far as like Flomax and Prostar, that they could potentially cause cancer, and they mislead the male as to the fact that because the urine flow is improved, that everything's fine. And I just was curious, again, it's an awkward question, would you prefer to use saw palmetto, Flomax, or Prostar?
I try to use a thing with least amount of side effects first, so I would probably go with saw palmetto, but again, testing and see what's most effective on the patient. If you can get away with something more natural and not as much side effects, because saw palmetto is probably least side effects, and make sure that they're lowering their levels. So that would be my first go-to. If that doesn't, and then as I said, spironolactone or zinc. I mean, adding saw palmetto plus zinc, and even adding progesterone. That blocks both. It'll block your aromatase inhibitor, and it's also a 5-alpha reductase inhibitor. So I think that, did I answer your question? Okay,
Thank
thanks.
you.
Uh-huh.
For testing, are you using the same type of test on the men as you're using on the women as far as ZRT and salivary?
Well, if they're taking a topical, then I have to do a salivary testing. But if they're doing injections, then I can do serum, and then the serum's covered by their insurance. So usually my guys, I usually do serum testing, because most of them are on injections. But if they're on topical, then they have to do saliva.
How about the baseline before you start any kind of hormones being introduced?
They can all
the
do
guys
serum.
want the serum?
You know, I do all serum on a baseline because it's covered by insurance. When you get to the salivary testing, a lot of insurances don't cover that, and they're not on hormones to begin with, so I can get a baseline to see where they're at, and then I can judge how much hormones they'll need from their baseline. Okay? All right, where were we? So these are other aromatase inhibitors to prevent the estradiol, anastrozole, chrysin, progesterone. Anastrozole, these are prescriptions, and that's supposed to be cheaper now because anastrozole is now gone generic, and it's covered by their insurance. We kind of talked about this a little bit. 5-alpha reductase inhibitors, zinc, progesterone, salpamental. Berberine is also a 5-alpha reductase inhibitor along with DHA. The use of HCG in young males with low testosterone, this is, you know, I talked about that previously, is, you know, the first thing, HCG is a subunit that mimics LH and FSH, so in order for this to work, you need to make sure the LH and FSH levels are normal, and the dose is between 1,000 to 5,000 units per week. This is another alternative to help males with low testosterone, is just giving them cytosine M, which is adrenal, orchid and thymus and spleen glandular components that are used for glandular function. You use 1 to 2 tablets 3 times a day with meals. So summary to all this is balance everything. You got, it's all to achieve optimal health, you got to balance the body. You got to give the body what it needs. The body is a miracle. If you leave it alone and you just support what it's lacking, it'll heal itself. I'm a true believer in that. And so, and you want to maintain balance and not go excessive, because there's consequences to that too. I never give estrogen orally. I never give testosterone orally. I never give Triest. And you know how to balance the hormones, and you want to know how they're metabolized too, so you don't do more harm. So you want to make sure that you're metabolizing more down the 2-hydroxy pathway. And then I also want to make sure you remember that if you ever give prenatal vitamins to anyone, check a ferritin beforehand. Never take vitamins randomly. Know what your needs are, because we have the testing, so test. So you don't end up like I did and, you know, trying to survive.